So you can just go to have some coffee if you want while I'm talking. My name is Ingrid Rekeland. I work at Haukeland University Hospital as a medical doctor, and I also work in the Øystein and Olav Mella's group with ME patients. Since 2004, when Olav and Øystein first discovered, I think I should probably take the next. No, sorry. Since 2004, when Øystein and Olav had their first patients with response on ME symptoms after lymphoma treatment, the hypothesis has been if ME-CFS is caused by an immunological pathomechanism. Maybe it is some variant of an autoimmune disease in a subgroup involving B-cell subsets and maybe autoantibodies. Or some other slow alteration mediated by the B cells. But what are the biological effector system for ME-CFS symptom maintenance? Which symptoms in the body are disturbed by this abnormal immune response? Some supportive observations for an immunological pathomechanisms in ME is the pattern of responses and relapses after B-cell depletion therapy. The lag time for response are in line with B-cell depletion therapy and some other established autoimmune diseases. And the B-cell lymphoma risk, especially the marginal low-grade B-cell lymphoma. This is an antigen-driven neoplasia associated with autoimmunity or with chronic infections. We also know that there is a high frequency of autoimmunity in relatives. In our studies, there are more than 40% that has first-degree relatives with one autoimmune disease. We know that the disease go into some families. Some families have disease in more than one generation, or they have more than one sibling affected. Mainly female are affected. 3 out of 4 of the adult ME-CFS patients are women. And usually there is a sudden start, 70% after infection, also other immunological triggers. And an autoimmune basis has been suggested for partly overlapping syndromes like POTS and complex regional pain syndrome. So this is nearly the same as Øystein tried to explain to you earlier. Now I will try to go a little bit more into this hypothesis with the B-cell depletion and the X factor. This is a response curve of a patient. The green one, and at this point we give the rituximab and the B-cell depletion. And as you can see, there is a lag time of the response curve between the B-cell depletion and when the patients start to respond. And this lag time, if we have something in the blood like this X factor, and this slowly eliminates after B-cell depletion, then suddenly it reaches some CFS response threshold. And then the curve gets up and the patient feels better for a period. But this is only until the X factor reaches the CFS response threshold again, and then the patients have a relapse. We think that this might be an autoantibody. And then we also can explain the longer responses, like this one, where the X factor is below this threshold for quite a long time. And this is the short responders, where the X factor is below the threshold just for a really short time. And this is what happens maybe for some of the non-responders, that the X factor never reaches the threshold. And maybe something here happens with the very long sustained responders, that the X factor never reaches the threshold again. you get some kind of a reset in the immune system. This is just a hypothesis. Okay, so what is the biological effector system for the symptom maintenance in ME/CFS? Which system are disturbed by this abnormal immune response? The main symptom is fatigue, so it's quite logical to ask the question if ME are caused by an energetic defect. Some other explanations, some general explanations for fatigue are depletion of intracellular energy metabolism, like diseases with the mitochondria that are known and described, increased lactate when you are, for example, running a marathon, and if you are not getting enough oxygen or you're not getting enough nutrients. That was just general explanation for the fatigue. There have now been quite a few studies with ME and metabolism, and the main findings are now going in the same direction. They have found impairment of metabolic pathways and early increase in the lactate on exertion. And we can't go into all of them, but... And there are also quite a few studies on amino acids with the main findings in the same directions. Our group published in December in 2016 a research article, Metabolic Profiling Indicates Impairment of PDH Function in ME. This is quite a complicated article, so I will now try to give an overview of the main findings. So, mitochondria, the energy factory of the cell. The body needs ATP, and the processes inside the mitochondria need to be running at all times to make the energy. To be ready to increase production of ATP quickly when the energy needs of the cell and the body change. So it's not only sugar that can enter this pathway, but it's also amino acids and fatty acids. And the sugar enters this pathway and goes into the mitochondria. And the PDH complex is a key enzyme in this regulation. And if you don't have enough oxygen, then you will go anaerobic and then you will produce lactic acid. So if you have oxygen, then you will, all the system will work, then you have a lot of energy, the ATP. So, this is the hypothesis, that there is a metabolic obstruction of the central energy pathway in ME. This is quite a difficult slide, but if you just look at this point where the glycolysis, where you have glucose that you have from your food, it goes to the glycolysis, and then you have it into smaller pieces and end up in a substance called pyruvate. And the PDH, pyruvate dehydrogenase, is an enzyme that converts pyruvate into acetyl coenzyme A that can enter the tricyclic acid or the citric cycle, which again gives all the energy. So there are many steps and many enzymes involved, and we just try to kind of have the overview. So we analyzed 20 standard amino acids and their derivatives in 153 ME patients and in 102 healthy controls. And there were only the non-fasting subjects included to make the groups more similar. And thanks to the clinical trials, we have a lot of clinical data, body mass index, disease severity, disease duration, and physical activity, and the quality of life schemes. So we can correlate to this when we are analyzing it. And then we analyzed it through the main routes of catabolism. The category 1 amino acids are catabolized to pyruvate. And the category 2 amino acids catabolized to acetyl coenzyme A. And the anaplerotic amino acids, they enter the TCA cycle at different places to maintain the cycle capacity. So this is just how we chose to analyze them, to understand our findings. So the category 1 amino acids catabolized to pyruvate. As you can see, there are no difference between ME and healthy controls, neither in men or women. And for the category 2 amino acids, the ones catabolized to acetyl coenzyme A, then you can see that there is actually quite a big, significant difference in ME women, which are lower level than in the healthy controls, but not in men. Same with the anaplerotic amino acids, which enters at different points in the TCA cycle. They are significantly lower in ME women than in the controls, but in men it's the same. And what is important is that the values are overlapping in both groups, so this is only on group level, and also the level are within the normal range. So it's just a reflection of the amino acids in the body. It's not a true deficiency. So the amino acid profile in serum indicates a reduced flux via the PDH complex. If you have a blockage here, then the amino acids above the blockage will be the same, and under will be lower, because they can enter independent of the PDH complex. So we think that these amino acids maybe are used as alternative source of energy. So what about the males? They were, sorry. We analyzed one marker, which name is 1-methylhistidine, is a marker of dietary protein uptake, and we found from the diet, and there were no difference in men or women. But then we analyzed another marker that is a marker of endogenous protein catabolism, which means from muscle cells. And then we found it's significantly increased in men with ME-CFS, but no difference in women. So this might indicate that the increased endogenous protein catabolism, that the men try to fuel the system in another way to compensate, maybe for the same obstruction. The PDH complex is closely regulated to according to the energy demand in the cell. And there are a lot of different things that contribute to this regulation. We analyzed the lymphocytes in 73 ME patients and 43 healthy controls, and we found an increase in the mRNA expression of some enzymes inhibiting PDH. The name is PDKs, SIRT4. Anyway, this means that there are more proteins or enzymes inhibiting PDH in ME patients than in the healthy controls. So, then we have that in women, the amino acids converted to acetyl coenzyme A maybe are the alternative fuel in women, and amino acids from endogenous protein catabolism, alternative fuel in men, if we have a blockage here. And then we also have some enzymes that are inhibiting PDH complex, which are upregulated both in men and in women. And we think this fits together with the rituximine and the cyclomy through signal transduction, and that this signal transductions changes in some way the energy signaling in the cells. So, as a conclusion, the amino acid profile in serum indicates redox flux via the PDH complex, and this might indicate a possible obstruction in the energy metabolism in the level of PDH. There are upregulation of this inhibiting enzymes both in male and female, so there is PDH inhibition in both male and female, but the sex-specific compensation mechanism. But there are no deficiency of the amino acids. The reduction is on group level, so this is not a biomarker. Reflects an altered energy metabolism in ME/CFS. So this metabolic obstruction in the level of PDH can explain some of the core symptoms of the disease. This devastating lack of energy and the lactic production at a low workload. One of our co-workers in the project, Katarina Lien, she takes her PhD on CPET, the cardiopulmonary exercise test, and she has found that ME patients produce lactate earlier than the healthy controls and at a lower workload, and especially the second day with repeated testing, like has been showed in other studies. And this fits with this model that you end up here with the lactic acid earlier if you have a block in this level, and you get less energy out. And then we were thinking, if this amino acid profile, could there be any other explanations? So we checked the fasting and the diet habits, and we found that the triglycerides are equal in ME and CF in the ME patients and the healthy control group, and the triglycerides are reduced by fasting. And we looked at other clinical data. The amino acid profile could not be explained by body mass index, physical activity level, severity, duration, age, or the fasting state. So we don't think this is deconditioning. And also this sex-specific reduction in amino acids argue against deconditioning as the main mechanism. So Ola Mella said in some conference that it's in the blood. So that was, a lot of people liked that quote. We think that there is a serum factor that is affecting the energy metabolism in ME/CFS. We found it in the lymphocytes. That means that it's in the whole body. So we think that this is a systemic problem, and we think that there is a serum factor. So in this experiment, we try to get closer to this serum factor. We have used the C-host instrument, and then we have the commercial muscle cells, incubated it with the patients or control serum for 6 days, and then we used the C-host instrument to measure rates of oxygen consumption and lactate production. And what is quite interesting is that the cells that were exposed to ME serum, they changed. They are different from the healthy control serum. They have more lactate production when they are stressed, like chemically stressed in the seahorse instrument. And they have changed mitochondrial respiration. So we are really working harder at the laboratory to understand what happens here, and we are doing a lot of laboratory work with this seahorse machine and with the serum from the ME patients to get closer to to answer to this question. So, as I've said earlier, this block can explain some of the lack of energy in the patients and the lactic production at a low workload. It looks like the patients are using the anaerobic metabolism, although there is probably not a lack of oxygen, and that the PDH inhibition resembles the physiological mechanism that are activated by fasting or starvation or by exercise, like running a marathon. But in ME patients, it looks like these mechanisms are activated at rest or at least at a minimal exertion. So, is this really the functional inhibition of the central energy pathway? Is this the biological effector system for the symptom maintenance in ME? It varies among patients and over time and in individual patients. And the consequences are pronounced when it's challenged by exertion and it's less visible at rest. In some patients, the process can be reversible, like with spontaneous recovery. And we think that this inhibition is caused by an immune response, probably since they have remission after B-cell depletion or cyclophosphamide. And we think it involves the B-cells in some way, or maybe autoantibody, at least in a subgroup of the patients. So we think this antibody or serum factor are interfering with the signal transduction and are affecting the PDH complex. So this is the map by now. So over the years to come, we will probably know if we are on the right track.